Transesophageal echocardiography has become an important tool in cardiac arrest resuscitation, allowing clinicians to visualize and manage arrest physiology without interrupting cardiopulmonary resuscitation. Unlike transthoracic echocardiography, TEE provides continuous, high-resolution images through the esophagus that remain unaffected by body habitus or ongoing chest compressions. TEE allows for real-time cardiac imaging without pausing compressions, giving healthcare providers continuous insights into cardiac motion, preload, and compression quality. This capability is particularly valuable in situations where transthoracic windows are poor, such as in cases of obesity, trauma, mechanical ventilation, or during defibrillation procedures. The technique is especially useful in identifying reversible causes of cardiac arrest, including cardiac tamponade, pulmonary embolism, aortic dissection, or intracardiac thrombus using standard mid- and upper-esophageal views. Early detection of these conditions enables faster targeted interventions, such as pericardiocentesis or thrombolysis, which often improve the likelihood of return of spontaneous circulation. TEE also helps determine whether the heart is truly contracting or merely showing electrical activity, distinguishing between PEA and pseudo-PEA. The technique allows clinicians to assess the compression vector and site, with studies showing that repositioning compressions over the left ventricle instead of mid-sternally can significantly improve hemodynamics and end-tidal carbon dioxide readings. Trials conducted between 2024 and 2025, such as the EXECT CPR study, demonstrated meaningful improvements in return of spontaneous circulation rates and better neurological outcomes when TEE guided chest compression positioning. In terms of procedural guidance, TEE enhances the safety of advanced procedures under arrest conditions, including catheter placement and extracorporeal membrane oxygenation cannulation. The technique is increasingly being integrated into emergency and intensive care unit protocols for both shock and cardiac arrest settings, as recommended in 2025 resuscitation updates. In cardiac arrest, both traumatic and non-traumatic, TEE has emerged as a real-time guide for resuscitative endovascular balloon occlusion of the aorta. During insertion, TEE visualizes the guide wire and catheter in the descending aorta, confirming placement in the correct zone, such as Zone 1 above the diaphragm, even amidst ongoing compressions. This is particularly valuable in low-resource or radiation-free environments where fluoroscopy is not available. After return of spontaneous circulation, TEE remains essential for monitoring balloon deflation, ensuring smooth reperfusion and preventing ischemic complications. It also provides immediate feedback on aortic flow, ventricular filling, and thrombus formation during the post-resuscitation phase. Recent systematic reviews in 2025 confirmed that intra-arrest TEE shortens cardiopulmonary resuscitation pauses, improves return of spontaneous circulation rates, and reduces overall resuscitation time compared to standard transthoracic echocardiography-based approaches. However, implementation requires adequate training and coordination between emergency physicians, intensivists, and sonographers. Centers adopting resuscitative TEE programs emphasize credentialing, simulation, and team rehearsals to ensure safe and rapid use of the technique. In summary, transesophageal echocardiography in cardiac arrest has evolved from an experimental tool to becoming the standard of precision resuscitation. By merging diagnosis, hemodynamic monitoring, and procedural guidance into one continuous view, TEE enables healthcare teams to act faster, smarter, and safer when every second and every beat counts.